So we have a pop quiz after this. So what was that? E.T.'s best friend, Stephen King's underground tunnel to the Neverworld, Denver's haunted Halloween cavern, or the newest mass transit tunnel in Europe? That's a what? Definitely D. Okay, so that was definitely the video of a colonoscopy procedure. And in the presentation today, we're going to cover really a three-pronged approach to this. And the first is to talk about what we do in the pharmacy with dispensing the prep that patients use for the colonoscopy. We'll talk about that. And then we're also going to talk about why the prescriber prescribes that certain prep, and then also about the procedure. So I want to introduce my speaking partner, Dr. Sullivan. He is a prescriber. Thank you. So he's a prescriber and he does the colonoscopy procedure. So Dr. Sullivan, how long have you performed colonoscopies?
I probably am on year 22 of doing colonoscopy. So.
Okay, so 22 years of colonoscopies. About how many would you say you've done?
Oh my gosh, probably over 8,000, I would say.
So
busy. It's a busy world.
So with 8,000
Both.
So with 8,000 colonoscopies, you have a lot of experience to talk about this. And the objectives that we have are to recognize the prep products that are dispensed in the pharmacy. And again, describe why the provider prescribes that prep that is prescribed. And then just really go over kind of the high notes of the actual colonoscopy procedure. So let's start from the beginning. What do we do with the prep? First of all, what is a colonoscopy? A colonoscopy is a visual procedure where the provider has to see the colon, the lining of the colon. So in order to do that, we have to evacuate or clean the colon. So our job in the pharmacy is to provide the patient with the prep that's used to clean the colon. Now, the most common prep used is Miralax, and it's a real common over-the-counter, not prescribed. But even though it's over-the-counter, as pharmacy technicians will still help with that. The patient will present at the counter possibly with a teaching sheet. This is what I need. I'm going to have a colonoscopy, and then we can lead the patient to the area in the pharmacy that has the Miralax. That's certainly something the pharmacy technician can do with the Miralax. And there's going to be another step. We want to make sure the pharmacist knows that the patient's having a colonoscopy. We'll talk about that in just a little bit. So Miralax is a powder, and that powder is dissolved in solution. It can be water. Most commonly it's Gatorade, and we'll talk about that. And when it's the Gatorade, it should never be a red colored Gatorade. It should never be a purple, like grape Gatorade, and it should never be orange. And the reason for that is because those colors have a tendency to stain the lining of the colon. So when this visual procedure happens, the provider can see something differently than what's actually there because of the staining. So the Miralax is mixed with 8-ounce glasses of Gatorade. And the patient has to drink that 64 ounces within a 4-hour time frame. Let's talk about why Gatorade. So Gatorade will replenish the electrolytes that the patient loses when they are having their bowel movements or evacuating. It'll replace those electrolytes. So that's why it's preferred to do the Gatorade. So the Miralax, over the counter. Let's talk about a couple of commonly prescribed preps. So one of the, it's polyethylene glycol, or PEG, commonly known as PEG. And the brand we have is the New Lightly and the Go Lightly. You can see when it's dispensed, it looks a little bit different. It comes in this 4-liter jug. So 4 liters is a little bit more than a gallon. And then this still has a powder in it. And then the patient mixes water or a solution with that powder, and they have to drink it. And have any of you ever done a prep for a colonoscopy? It's tough. And I think you can all agree it is tough to drink 64 ounces within 4 hours. And it has to be consumed or drank at least 12 hours before the procedure for this prep to be effective. So I think there's kind of when we're forced to drink it, it's even harder to drink. So in looking at this, I thought, okay, that's a lot to drink. Now there is a tablet. It's called Sutab. So there is a tablet for a prep, and we just need 2 doses of it. So I looked at this and I thought, why isn't Sutab the star of the show? Instead of all of that powder and all of the glasses of water, but upon further investigation, just 2 doses is 24 tablets. So 1 dose is 12 tablets, and the patient still has to drink the 64 ounces of fluid. So really, there's a reason why we don't hear much about Sutab. It is not the star of the show, because actually we're still drinking the same amount of solution, plus we have to get the tablets down our throat. So that's a little bit about the prep that we're going to give out in pharmacy. Now we'll talk a little bit more about other things to do, because I realize there can be some allergies to the polyethylene glycol. So we'll cover that in a little bit. But I wanted to ask Dr. Sullivan, have you ever gotten ready to perform that colonoscopy and you have found someone did not prep?
Unfortunately, yes, I have. Not the most pleasant experience in the world. Part of my preoperative interview with the patient is I'll ask them, hey, how'd the prep go the night before? Just want to make sure that they had some results. I've had to cancel procedures if, I've had patients say, you know what, I did the whole prep as instructed and I didn't go to the bathroom at all. So I'm probably not even going to try that one. I had a patient, I'll never forget this. I asked him, hey, how'd last night go? And he said, went great. Okay, well, to me, that means his prep probably went pretty good. Get into the endoscopy suite, and within 30 seconds, I knew I wasn't getting through this colon because he was not cleared out at all. So I canceled the procedure. And when I asked him afterwards, I said, I thought you said everything went great last night. And he goes, it did. And I go, well, what about your prep? And he goes, what's a prep? He just showed up for the procedure without prepping. So yeah, it can be ugly.
You heard it from the horse's mouth. It can be ugly. So Dr. Sullivan, some people might be questioning. So you start your procedure, the patient hasn't evacuated their colon the way they should for you to properly do the procedure. Maybe they tried and maybe it just wasn't effective. So then what's the next step? Because they need the colonoscopy.
Yeah, so we'll reschedule the patient, and I'll usually recommend a 2-day prep. And it's basically doing the same thing 2 days in a row. I know it's kind of hard because you can only eat a clear liquid diet the day before. So doing that 2 days in a row is not the most pleasant thing for people, but 2-day preps usually are very effective.
Very good. We're learning a lot here. So this is a family picture. And this was taken in the early 80s, and I was 11, 12 years old. And I'm sharing this with you because my dad passed away. I want to do this. He passed away when he was 42 from colon cancer. And we're going to talk a little bit more about that and relate that to our presentation, because as we go through, we'll talk about signs and symptoms of colon cancer. But I wanted to share this picture. My oldest sister, she is to the left of my dad, so on your left side. And this was her senior picture. You know how when you get senior pictures, they kind of give you a package deal and you do your family. So that's what this picture was. And so I think just moving on to, again, what we're going to do in the pharmacy as pharmacy technicians is one thing is just recognize the patients coming in for this prep. And most of the time, the prep is preventative medicine. You know, it's that every 10 years, I've reached a certain age. But sometimes it's for diagnostics. Sometimes they're prescribed this because there's a health concern. So as technicians, realizing and just empathizing why the patient's coming in. And certainly we're helping them. So that's kind of that soft skill part of what we do. And more of the workflow part of what we do then is showing them where the product is, helping them, you know, dispense the product. We can look on the patient profile. Are there medications that may be contraindicated? So medications like the GLP-1, that would be the Ozempics. That would be something we want to alert the pharmacist to. Hey, there's some medications on the patient profile. Patients having a colonoscopy, getting a prep. Some others would be blood thinners, Coumadin. Those are things, look on that profile. That's the workflow things. It's always good. The pharmacist will look at that. And also you heard from, like I said, the horse's mouth or the provider's mouth, that how important the prep is. And sometimes the patient doesn't do the proper prep. Hopefully they've received teaching in the office from the nurse or from the prescriber, but it never hurts to have the pharmacist do some counseling too. So as a technician, you know, knowing the whole full gamut of this patient coming in, what's going on, what's going to happen after they do their prep, and the importance of just another set of eyes on what's going on and the pharmacist to talk with them a little bit more about it.
So I'd like to go into a little bit about why we do what we do, mainly colon cancer screening. Colorectal cancer is the third most common cancer in humans. And it's the second leading cause of cancer death in both men and women. So as you can see, it's a very common cancer. One that if we implement our screening techniques, we can avoid for the most part. It's estimated that colon cancer is expected to cause about 53,000 deaths this year. We do our best for screening. It's estimated that we do about 15 million colonoscopies every year. We can always do more, that's for sure, because we're behind on screening. The top causes, by the way, of cancers in men and women are breast and lung. So EOCRC, that's early onset colorectal cancer. We still don't have it nailed down as to certain things that cause colorectal cancer. There's a lot of differences between the studies. We're trying, you know, obviously if we can nail down a cause, we can prevent with lifestyle mods and that type of thing. But we want to concentrate on mitigating modifiable risk factors. So there are modifiable risk factors and non-modifiable risk factors for early onset colorectal cancer. So some non-modifiable risk factors we know about are the male sex, Caucasian race, and family history. So these are non-modifiable. Obviously, you can't change your genetics, that type of thing. And so, some modifiable risk factors we know of would be obesity, hyperlipidemia, smoking, excessive alcohol consumption. These are risk factors for pretty much most cancers that are out there. So these are just what we know about. So we're working vigorously to figure out if there are any other risk factors. So screening, we have several modalities of screening, what we like to do. Fecal occult blood testing, that's probably the one that's been around the longest. It's a test that we generally do every year. There's sigmoidoscopy, which we want to do every 5 years. The Cologuard stool test, that's one we do every 3 years. And then the gold standard colonoscopy is one we do every 10 years if it's normal.
So let me talk to you about the first one, the fecal occult blood. And I want to talk to you about this one because this is one that we hand out in the pharmacy. So occult means hidden, fecal, feces, stools. And again, it's a test that once we hand it out in the pharmacy, it's free. We hand it out, but then we depend on the patient to do the test. And in my opinion, I've never done this test, and I'll show you why right now. And it's not the easiest test to do, but it's free. And for some patients, it could be very convenient. So you get it at the pharmacy and you see the 3 sticks there, and then you see the card that says 1, 2, 3. So what the patient has to do is have a bowel movement, and in 3 different areas of their BM or their feces, they have to take a sample and smear the sample on slot 1, 2, and 3. And they have to do that for 3 different bowel movements. So it could be for 3 different days. So where am I going to store this? I'm not quite sure. But anyway, and I'm making a joke of it, but it's a good test. But keep in mind that this is only going to test for blood in the stools, period. That's the only thing it's testing for. And you're depending on the patient following the instructions on how to do it. So once the patient has the 3 different samples from 3 different stools, they mail it into a lab. And there's directions or instructions on the kit of where they mail it into.
So another form of screening procedure that we do is a sigmoidoscopy. And unlike the colonoscopy, which is a longer scope, because it goes through the entire length of the colon, the sigmoidoscopy only gets to about half of the colon, i.e. the sigmoid colon. So we don't visualize the entire colon. And for that reason, that's why we want to do this test every 5 years to make it accurate. This is I used to do these in my office, in an office setting, no sedation. And usually the prep involves an enema. So this procedure has kind of fallen by the wayside. It's not a preferred. If you're going to do a procedure, you might as well look at the entire colon. We put you to sleep. So it's kind of fallen out of favor as a screening test. Probably have heard of the Cologuard, seen it advertised on TV. The Cologuard test is a newer stool test. It actually detects DNA of polyps. So it's a much more accurate test than just the fecal occult blood test, because all we're picking up is blood in the stool. Many, many things can cause blood in the stool, not just polyps. So Cologuard is specific to actual polyps. It picks up DNA of polyps. You likely won't see this roll through your pharmacies, because when I order a Cologuard for a patient, the order goes directly to the manufacturer and they mail it to the patient. So the pharmacy is bypassed. That's one that we do. If it's negative, we do it every 3 years to make it accurate.
This means I am going to ask him a question when he steps to the side. So I think people are probably wondering, why would you ever, you've already told us that a colonoscopy is gold standard. So why would you ever prescribe Cologuard instead of a colonoscopy?
That's right, Judy. I try to talk people into doing the full colonoscopy. It's the best test that we have. However, based on certain patients' health and age, going through a procedure might not be the greatest thing for them, but they still need to get screened. So the Cologuard is a great alternative. You hope that it's negative, because if it's a positive test, I still have to go through with a colonoscopy. You also avoid a prep. So sometimes patients can't tolerate a prep. So the Cologuard is a fantastic alternative. It's not one that we want to rely on. As a matter of fact, if you have a history of polyps, Cologuard is not an indicated screening test for you. Or if you have a family history of colon cancer, we shouldn't use the Cologuard for screening.
Would it be a good option if someone's allergic to the PEG or polyethylene?
Yeah, that would be a perfect option. That's on me, okay.
We're used to how we jog. You are on
Yeah,
that side.
right. I'm on the wrong side.
There you go.
Okay, colonoscopy. Colonoscopy is the gold standard of colon cancer screening for the reason that it's a visual test. We visualize the entire length of the colon. If polyps are found, I can remove that polyp right then and there. So I don't have to bring it back for another procedure. So polyps are benign growths on the wall of the colon. We know, though, that colon cancer grows from polyps. So we consider polyps to be precancerous lesions. So if you have polyp, now not all of them turn into cancer, all the time, but this is why we do what we do. If you have polyps, we want to get them out of there because they have a potential to turn cancerous. And usually, like I said, when I do a colonoscopy and I see a polyp, I can usually remove it right then and there. There's a couple of ways we do it. Shown here is a snare. It's a little wire snare, and most polyps are pedunculated, so you can just take that snare and clip them off. They're usually very small, under 1 centimeter, so that's pretty tiny. So the trauma to the wall of the colon is very minimal. There's another way of using a forceps. It's like a pincher where I can just clip off polyps that way too. So here's what it looks like. The patient obviously nicely sedated, laying on their left side. The procedure itself takes 20 to 30 minutes. So once I put the patient to sleep, we insert the camera and drive it around the full length of the colon. Again, it's a visual test like you saw at the beginning of the presentation. And I just visually look for polyps. If I see them, we go ahead and remove them. It takes about 20 to 30 minutes. And like I said, nowadays we use propofol for sedation. And I always tell patients, you'll know why Michael Jackson loved that drug so much. So,
I told him not to say that.
well,
He just got a kick back here.
Yeah. Well, he was using it to go to sleep every night. So not a great idea. So colon cancer, we label colon cancer as the silent killer. So when people have polyps and those polyps are beginning to change into cancer, that takes a long time, years and years for that process to happen. So usually by the time people start having these red flag symptoms, such as rectal bleeding, abdominal pain, unintentional weight loss, change in bowel habits. So if a patient is becoming symptomatic from colon cancer, it's usually a very advanced stage. So I can't emphasize enough the importance of screening, because we want to get in there and pull out these polyps before they're getting to an advanced stage. And usually people are asymptomatic.
So this is where I kind of wanted to step in and talk about my dad and if he had signs of his colon cancer. So I talked to Mom about this. I was 16 when Dad died. And so I talked to Mom. did dad ever have a colonoscopy? And she has no idea if he did or not. But she said from the time they met in the mid-50s, he had bowel problems, and he would get on medication and then he would feel like $1 million. And so then, the problems that he had, were kind of dimmed and probably didn't take care of them the way he should have. I personally remember, so there were 6 kids in our family, and we always sat in the second pew from the last in church. Like, we didn't get to sit up there, and I figured it's because my brothers, they were loud. But now I know it's because dad needed to be by the bathroom while we were in church. So he definitely had the signs and symptoms and had them for years. And I think that it started out as some GI issues and then probably wasn't taken care of the way it should have been. So he had, even though it's silent killer, he did have some signs.
Yeah. So what are the recommendations in traditional recommendations were that all men and women should start colon cancer screening at age 50. 2018, the American Cancer Society recommended lowering that age. So all you 45-year-olds in here, lucky you, get screened. So we move the age 5 years to the left. And this is a direct result of data that has come out that we're finding colorectal cancer in younger and younger people. And it's such a prevalent cancer that's why we made this age recommendation. And it's a big deal in medicine when you do that, because look at all the people you have to screen now from age 50, now it's 45. We think that we can prevent almost 30,000 diagnoses of colon cancer and avert 11,000 deaths just by moving that age 5 years. So there are about 19 million adults age 45 to 49. So that's 19 million folks that need to get screened. Right now, we're only screening about 4 million of those. So there's 15 million people out there walking around overdue for screening. Some might be in this room. So again, only about 30% receive screening recommendations from their provider. As far as the overall incidence of colon cancer, the incidence is declining, and it has been declining since the 1980s. And this is a direct result of our colon cancer screening methods. We have a much higher efficacy of screening, i.e. the colonoscopy. Our techniques have really been honed. We are really getting the word out to people, and I hope you guys would too. Public health campaigns for people to get screened. Screening rates have actually increased from 19% in 2000 all the way up to 55%. So we're getting there. We still have, 50% of people we need to screen, but things are much, much better. And because of that, the incidence has gone down.
So we are ready to summarize. And so I thought, in summary, maybe to bring the story full circle, see if I can use my pointer. I know that, well, I can't. So the guy in the middle, does this show the pointer? This doesn't show the pointer. So my brother kind of kneeling with that look on his face. That's Fred. He gets his colonoscopies. Family history, we're supposed to get those. I get my colonoscopies. Fred, I will tell you for sure, is not going to listen to his prep instructions from his doctor. And so when he comes into the pharmacy, getting that knowledge from the pharmacy is going to help someone like him too. I know that my brother down here, next oldest brother, Tom, with the big part in his hair, not the straight banged one. I know he gets his colonoscopies too. So the others, I don't know if they get them. I don't know if they get them or not. I haven't talked with them about them. I just happen to know the other ones. So yeah, with the family history, really important to get those. I think we got this. And I think just in summary, hopefully the presentation today has helped you understand, like I said, just the full circle of it's more than just picking up an over-the-counter Miralax product. There's a lot more that's behind the scene to be aware of and to really provide that service to your patients.
Yeah, and I'd just like to emphasize again the importance of screening. Again, it's a silent killer. By the time patients become symptomatic, it can be too late. I have scores of patients where I talk to them, hey, let's get your colonoscopy. Well, I don't think I need that. I feel fine. Why do I need, I'm not having any GI issues. And for this very reason, they need to get screened. So
I know that all the questions will be for this guy. So that serves me as well, but please, we've got time for questions. So go ahead.
yeah.
I think it's magnesium citrate.
Yep. Yep. So the question is magnesium citrate. So that is one that we use. Obviously, if you have that PEG allergy, we do not, there's a lot of benefits to mag citrate, right? They're small. You're not drinking as much over the counter, and it's very efficacious in clearing people out. The problem is when we were using that commonly as a prep, it was causing renal failure in patients because the electrolytes the fluid shifts were so big. So in general, I don't like shutting down people's kidneys for an elective procedure. So we don't really use that as much anymore, but it would be a good alternative for you. Yes. I have not personally seen a patient that had a positive, or I'm sorry, a negative Cologuard and then went on to have colon cancer. I have not seen that. Cologuard is very effective when it's negative. So the false negatives are lower than their false positives. That's why if you have a positive Cologuard, we got to go do a scope because I don't know if you have a polyp or not. But if that test is a negative one, we're very comfortable. There's no issues. And that's why we do the 3-year cycle too, to not wait that long. Yeah.
I could see one article that there's a
I haven't seen any hardcore data that that's the case. I've heard of that. I think they're still studying that. Yeah. Definitely a lot more people be on metformin if that were the case. Yeah. Right.
And sure, I forgot to mention that insurance doesn't pay for it. Yeah.
Yeah, she said the over-the-counter option is great, but you guys don't get to counsel the patient. Hopefully I did my job and counseled the patient and gave them good prep instructions before they left my office. But sometimes that doesn't happen, like the fellow that I tried to scope that didn't do a prep at all. Yeah. I diagnosed a young woman, age 24. She was having rectal bleeding, and I went in with the colonoscopy, and she had about a 10-centimeter mass that was already cancer, and she was 24. I just scoped her last year. She's in her 40s now, and she's doing great. She just had to have surgery, and very rare, very rare. Yeah. Really good question. The question is, where does ulcerative colitis fit into colon cancer? I would add that ulcerative colitis is under the inflammatory bowel disease category. Crohn's disease is also a condition that people can have. If you have ulcerative colitis and or Crohn's, you're at higher risk for colon cancer, having those diseases. So we tend to have a more strict schedule of screening for those, for people with IBD. So yes, you're more risk for getting colon cancer with ulcerative colitis. No, not at all. Irritable bowel syndrome does not put you at higher risk for colon cancer. Yeah, that'd be diarrhea predominant, IBS. Yeah. Again, I don't alter the schedule of colonoscopies if you have IBS. Yeah.
Then he has them had relax, physical, and fear test over top.
And this is for a prep. A little unusual.
He's in the hospital. He literally says that just go downstairs to the pharmacy downstairs and tell me what I get.
His kit. Wonder if he's getting kickback. Yeah, yeah.
Ask him exactly what is the rationale for this?
Yeah.
What's the rationale for that?
Couldn't tell you. It's unusual. Metronidazole antibiotic. The antibiotics are not indicated for preps, you know. Couldn't tell you. Yeah. Mm-hmm. Mm-hmm. Yeah, very, very good question. So polyps are growths on the wall of the colon. Again, we consider those precancerous. Or pockets, we call that diverticulosis. Not one is not related to the other. Diverticulosis, what that is where you develop pockets on the wall of the colon, and they're benign lesions. However, they could bleed. You can get infection from them, diverticulitis. So it's not a precancerous condition. Diverticulosis is not, but those are unrelated conditions. Yeah. Eat your fiber so you don't get those. Yeah. Uh-huh.
What is some good advice on relation of fact and acknowledgement of expertise that are split of what they've done?
Oh, absolutely. That's critical in any encounter. Obviously, you guys do the work of, dispensing what I order. I'm sorry. What's a good way to facilitate working working relationship with a pharmacy technician and a prescriber? Yep. And, I will say over my career, I've had outstanding relationships with my pharmacists and pharmacy technicians, because a lot of times they're calling me on the phone saying, Dr. Sullivan, are you sure you want to order this medicine at this dose? And I'm like, oh no, I didn't want to do that. So your role is critical in troubleshooting and making sure we're not dispensing or ordering things that there might be a patient out, drug allergy or inappropriate, how many times have physicians done inappropriate orders? So yeah, I think it's critical to have a good relationship with your pharmacy.